Okay, Tony, I think you're ready to go.
Thank you, Jay.
Yeah.
Tommy and Bridget, I'm Dr. Tony Dikiakio. I'm a doctor of nursing practice, family nurse practitioner. And this session, we're going to talk about the do portion of quality improvement cycle. Technically, I will say this is still technically part of the planning phase, but it's a very active part of the planning phase in a PDSA cycle. And the next session, they'll really talk about the whole PDSA. This is usually the part that people like the most in quality improvement projects because it's so active and everybody gets to give input and a lot of teamwork happens. So last time Katie talked about choosing a change team, and in breakout groups, you guys talked about who was going to be on your change team for your QI work at your settings. And then also focusing on how to identify an aim and do a walkthrough. So this is the next portion of that. Next slide, please. So specifically, we're going to look at flow charting today and a technique called nominal group technique. It's a brainstorming kind of session that you can add quantitative values and making decisions. Next slide. So flow charting is exactly what it sounds like. And probably you've seen a flow chart in either training manuals or your policy and procedures manuals or in school. And it's just a visual depiction of a process. And in quality improvement, it's basically the visual depiction of the process in which your aim or problem lies within. And it allows you to commit something to paper, commit what the whole process looks like from the patient's vantage point, and allows you to identify potential bottlenecks, transitions in care, problems that may be at the root of whatever problem or phenomenon of interest that you've identified. It also allows you to all get on the same page as a change team. So you all have the same understanding of what your process is in caring for patients. It really generally is recommended that in an ideal world, your change team can physically walk through a process as if you were a patient, say like walking in the front door, checking in, going to your intake appointment, seeing what that's like, and then, whatever next steps are, for example. Sometimes we don't have time to do that. So at least mentally, everybody on the change team walks through the process that will be mapped out in a flow chart. And then you'll all get together and I agree to that process. You can either have someone on the change team start the flow chart, and then when you all get together as a team, agree that that is indeed the process and nothing has been left out. Or at one of your early change team meetings, you can together put the flow chart together. Some practical tips. I would just say the most important part of a process or of a flow chart of your process is identifying the starting point and the ending point of the process in which you are charting. Because literally you will have, if you really think about it, hundreds, if not thousands, of interactions with patients in your setting. So you don't want to necessarily flow chart every single interactions or transaction that you have with a person, but where you've identified your first problem or aim to address. But keep all of your flow charts and label them appropriately because they're very useful in continuity of care and, like I said, training manuals, policies, procedures. So it's important to label them once you do make them of what that particular process is. Next slide. This is not something that I want you to get wrapped up in at all, but I did want you to know that there are, for flowcharting purposes, standard symbols that people use when they flowchart, and people that are in like industrial engineering, industrial or organizational psychology, project management, auditors. I did accounting and auditing for like 15 years before I became a nurse. So all these symbols are, we had to know. And back in my day, when I was an accountant, we actually drew these. We had these like little plastic carve outs, and we used to draw them on paper, starting point, you trace the oval. But these are the most common. And I wanted to show you because in the next slide, which is a sample of a flow chart, you'll see exactly how they fit in. So see how the start and end point is that little oval. And then the squares or rectangles are action items, and diamonds are decision points, usually yes or no answers. And in this very simple, very simple flow chart, you can imagine if an organization got a complaint from patients or clients saying, no one ever answers, I can never get an appointment in your facility when I try to call in. So administration or management's getting these complaints from customers or clients. And so a change team gets together and they map out what their process actually is. And it starts with the customer or patient or client calling the agency. And then a person, receptionist, answers the phone. Does she answer or he answer? Yes or no. And then if the receptionist answers, is that person who answered the phone able to help that person at that point of contact, or do they have to transfer it to another person? And then, of course, the receptionist or the front desk person is always supposed to thank a customer, client, or patient, and then hang up the phone. Very simple. But in this very simple flow chart, can you identify if the complaint your organization received was regarding difficulty getting in touch with someone to set an appointment? Where would you, and this can be any of us, our team or the sites that are with us tonight, where would you dive in to look at for more information to find out if there are particular barriers or problems in this flow chart, in this process? Anybody have any thoughts on that?
I mean, I would look at was the receptionist able to help?
Right, that would be a great point. Like, is the person that's actually answering the phone, are they someone that even, like, do they know where to send the person? Are they able to immediately, like, how many layers do you have to go through before you get to the person that can actually set your appointment? Another common one would be, is the receptionist actually answering the phone? Like, is everybody being routed to voicemail? And so diving in a little bit deeper into, and this again is a very simple example, but that's what flowcharting is about, identifying like, okay, this is how it's supposed to work, how much is working, and where can we examine the potential barriers or transition points. Next slide. So in this, this imaginary change team has identified their phenomenon of interest or their problem or aim as having a high percentage of patients that are lost to follow-up after they're leaving their detox setting and coming to their very first ambulatory follow-up appointment for ongoing treatment and an office-based MAP program. So between detox and first ambulatory appointment, they're losing them. They have a really high loss to follow-up rate. So just from your vantage point, and again, anybody in our team or on one of the other sites, the two sites that are watching, what would you think would be a good starting point? Because that's the starting point and the end point are the most important parts of deciding what you're going to flow chart. So if the problem is lost to follow-up between detox, discharge, and first appointment, where would you flow chart the start and end point for the process? The end point is actually the easier one of the two start and ends.
I would think the starting point would be a discharge.
The starting point could be a discharge, absolutely. And the end point?
I'm promise I'm not like throwing you off, but there's like somebody right outside my house right now. So can we pass that one off to somebody else right now?
Katie, what would you do for your endpoint of this?
Sure. So if Andrew suggested the start point be at discharge, then the end point could be, are they showing up for their very first appointment?
Yeah.
Or maybe a start point could be it's still actually while they're in inpatient or detox. And then an end point could even be maybe after they've showed up for their first appointment.
Exactly. I mean, I think you definitely would want your endpoint to be at very least at that appointment. I mean, that is logical, if they're showing up to that appointment that you want them in, but you could absolutely do it more. And while the discharge is a logical choice, that discharge from detox, that time point is logical. Again, you, like Katie said, you might want to do it even a little bit before discharge. So you can look at how patients are prepared before discharge for their follow-up with wherever they're going to go next. But you wouldn't want to necessarily do it from, the ED of your facility and the clinic the clinic time a year after sustained sobriety. That would be too long, you know. You want to focus on some finite processes. Next slide. Okay, so nominal group technique. I'll tell you, our QI team really liked this part. Every QI team that I've ever worked with, whether it's like Six Sigma or Lean, they might name them different things, not necessarily nominal group technique, but the brainstorming part of a quality improvement team is the most fun. And it's just an exercise to promote group ideas and concepts to test for improving whatever you have identified as your problem. And the way that this particular this technique that I'm going to talk to you about works is very systematic, and there are like specific rules set for it, and it makes introverted and extroverted team members engage, and it allows the group as a whole to identify priorities and objectively rank interventions to try. It's 5 steps. Next slide. And the first step is the silent idea generation. So last time we all got together, and the group that I was in, the discussion was of a particular problem or aim that they would like to have is people that have been in treatment for a while who haven't really got any major days of sobriety behind them. So just getting some sober days in this particular group that is part of their client base. And then the other group, I believe, talked about potentially retention as one of the ideas. And retention is one of the ideas that we did as our first project. 30-day retention in our QI team was our first aim. So the silent idea generation is, you know, the change team members sit around a table just quietly for 3 minutes, think of interventions or processes to change or policies to change, any ideas they have to improve whatever they're trying to improve, whether it be to improve retention, to improve sober days, to reduce no-show rates, to improve first show appointments, whatever it may be. So for 3 minutes, you all sit silently and just list quietly your ideas for interventions. And then after that, after the 3 minutes is up, everybody goes around the table and lists, and you have a recorder or a facilitator, whatever you want to call that person, that writes down what each person's ideas one at a time. So it would go like, Jay, what's your idea? Tony, what's your idea? Sheena, what's your idea? And then you go back around until when we get to Jay, he has no more ideas and I have no more ideas, you know, a final go around the horseshoe. And you're listing, and you're not talking about them. You're not criticizing them. You're not doing anything. You're just listing them. You're just listening to the people and listing them out. No judgment. And then after that, you get an opportunity for 4 minutes or so to ask clarifying questions. And again, it's not like, well, that will never work, or that's a stupid idea, or we've tried that before, because sometimes you've tried something before and it didn't work, but timing or team or process or whatever, it might be a good time for something that did not work before. So you don't nix anything. Nothing is nixed, but you can ask clarifying questions like, Olivia, what do you mean by having a special drop-in group? What exactly does that mean? And just to define those terms that are recorded or those ideas. Next slide. And the next step is the quantitative. Every member of the group has 3 votes, and they cast it on their top 3, and this is not weighted, just pick 3. So I would say, Jay, what are your top 3 choices for the intervention to pilot to see if we can improve whatever we're trying to improve? And then I would give mine, and Sheena would give her 3, and Olivia would give her 3, and Megan, and so forth. And then we just total the votes. We total what everybody says. That the one with the most votes rises to the top to be the first intervention to be tested. You keep your list because in rapid quality improvement, rapid cycle quality improvement, you always go back to other ideas. You do a cycle, you decide if you're going to keep or throw away or adapt some change that you've already made. And once you've made that decision, you go on to your next change if you're not satisfied with what you've achieved. So you don't throw away your ideas. And if there is a tie, if there would happen to be a tie, then there's just a one around the horseshoe with everybody casting a vote for the tied selections. Next slide. So we're going to try to do this really kind of quickly. And we're part of a change team, an imaginary change team, all of us in this room right now together. And what we're trying to improve is our no-show rate for scheduled intakes. For very outpatient, very first appointment, we have patients scheduled for addiction services and only 30% are showing up, which is abysmal. It's abysmal. And so we as a team want to figure out how can we make more than 30% of our patients show up for their first scheduled intake appointment. Now, in preparing for this so we can save time, I did a list of them. So if you could click the forward button again. So I'm just going to give you a minute. These are just things that I pulled from the internet that other people have tried or I've just seen as interventions. And I'll give you a minute to read these. And then I'm going to go through the horseshoe just one time and see if there's additional ones that anybody wants to add. And then we'll vote. Has everybody had it? Okay, good. Jay, do you have anything to add for potential things to pilot?
No.
Sheena, do you have anything to add for potential things to pilot? Olivia, do you have any?
No.
Megan, any thoughts, any additional interventions?
Nope.
Andrew?
No, not really. I mean, you could try using like big data as well, but that's not really engaging with the patient. So, no.
Katie, how about you?
No, right list.
JW, any thoughts?
No.
Bridget? Nope. Natasha?
Nope.
And Tommy?
Nope.
Okay, so I said we were going to vote, but before we vote, we have a clarifying time. Is there any questions about these interventions 1 through 13 or 1 through 12 that anybody has? Any clarifying questions? No judgment, just clarifying questions. Okay, so it doesn't look like it. Jay, we're going to start with you. What are your, and I'll keep a tally here on my list. Jay, what 3 votes will you cast?
I will do number 8, number 5, and number 2.
8, 5, and 2. Got it. Sheena, how about you?
I'll do 1, 6, and 8.
1, 6, and 8. Got it. Olivia?
1, 8, 9.
1, 8, 9. Great. Megan?
I will do 5, 8, and 9.
5, 8, and 9. Great. Andrew?
I was thinking 4, 5, and 9.
4, 5, and 9. Fantastic. Katie?
1, 5, and 8.
1, 5, and 8. Great, got it. JW.
I too am doing 1, 5, and 8.
1, 5, and 8. Great, thank you, Bridget.
3, 5, and 12.
3, 5, and 12. Got it. Thank you, Bridget. Natasha?
I'm gonna go with 1, 5, and 8.
1, 5, and 8. Got it. And Tommy?
1, 5, 6.
1, 5, and 6. This is a real nail biter. But we do have a winner. We do have a winner. The 5 got 8 votes, 8 got 7 votes, and 1 got 6 votes. So some really good ideas. But in this instance, we would try to do the reminder calls for a cycle, whether that be, and we'll talk more about this in future sessions, but depending on the intervention and the intensity of it, the resources you need, and the estimated time to notice an impact will decide how long you implement your intervention to measure. Something like a reminder call, you probably could know within 2 to 3 weeks if it's having any impact. You might want to do it a little longer, but it really wouldn't take that long to figure out if it's having an impact on no-show rates. And then you could either adopt, if it is, you could adopt it, you could adapt it to make it 40, like maybe 72 hours or, instead of 24 hours, whatever you pick, if you think it's gonna, you want to adapt it a little bit. If it's not making any difference, then you get rid of it and you trial the ride sharing program. So that's just a quick example of nominal group technique and how it works and how it allows for democratic processes to select interventions. Next. Oh, actually, we already did that. Okay, so any questions before we talk about going to breakout rooms and practicing nominal group technique and flow charting for the problems or aims that you all kind of picked or are discussing at this point? Okay,